So I was asked to talk a little bit about our approach to patients pre and post surgery. Specifically, we're going to talk about just the lymphovenous bypass and the lymph node transfer, because we have an expert who's going to be talking a little bit about the therapy approach after the liposuction treatment. So I dare not delve into that. Even though I took the pilgrimage as well to go visit Dr. Borson et al., I wouldn't deign to try to speak authoritatively about that. So, and I really can't, I don't know that I could speak authoritatively about the lymphedema therapy approach after surgery, because the number of patients I've seen compared to the total number of patients I've seen for conservative management is very small, and we're learning with each one. So as I was thinking about this and having talked about our approach last year, pre and post surgery, I really had to kind of take a step back and think, what are we doing differently this year? And talk to you a little bit about the changes, not only about what we're doing, but why each step. So if I could talk to you about my decision-making process as we see the patients, because we're really making decisions one by one. And then I also wanted to think a little bit more about our approach to patients, not just before therapy, before surgery, after surgery, but the whole spectrum of treatment of patients from when they call into our center to make an appointment to when we put them back onto a surveillance program after they finish with their surgical procedure, and how we think of that as a kind of a whole approach rather than specific episodes of care within that. And we get quite a few patients from outside centers, small practices, lymphedema therapists in the community all around New England. So these aren't necessarily patients that I've been following. So I thought we would go back to, I wanted to take you back to the beginning. And Dr. Single had presented the algorithm of how patients call in. So I thought I would start from back there, because they get triaged at that initial phone call. And if they have chronic lymphedema, they come in, even if they've seen something in the news or heard about a surgical treatment for lymphedema, they get scheduled to see our lymphatic medicine clinic first. They don't get to see surgery until they've gone through the rest of the team first. So that's, I think, an important step. They go through the lymphatic medicine workup concurrently with their first visit to the lymphedema treatment center. So they see Dr. Carroll in lymphatic medicine, and he sends them down, and I see them immediately afterwards, where we can take the baseline measurements and do our initial exam and talk to the patient. And that's really, I think, what we've changed, I think, since last year, and really taking a little bit more of a look at what the patient's history with lymphedema treatment has been in the past. We see some patients who are fairly newly diagnosed, clearly not even ready for surgery yet. They're so newly diagnosed. We see some patients who have very chronic lymphedema for many, many years. So asking a little bit more about their history of treatment. And I think what I've come to realize is to stop taking for granted when patients say they've had treatment already and it's failed, to really delve into a little bit more of the details of what that treatment entailed. Because sometimes they bring a bag of devices and sleeves that may be very old and stretched out and that they've ordered on the internet, and that's what they call they've had treatment for lymphedema. So then we have to start kind of at ground zero. So as we're doing the workup, really the main question for me when I'm seeing the patient is, has their conservative therapy been maximized? And that's the question. My responsibility to the rest of the multidisciplinary team is to ensure that the conservative care has been maximized before they move on to the next step in consideration for surgery. We certainly don't want people going into surgery until we've tried everything else first. So that's kind of like my first question. We take our baseline measurements, we calculate volume, we do bioimpedance, we use the pyrometer to take volume measurements. We're using a durometer to help us with looking at skin integrity, and also our quality of life measurements, as well as some functional scores, and overall asking patients what number of minutes that they spend in compression per week, because that's a nice indicator of quality of life for them, because most of the time the goal for most patients is to come out of compression. They hear there's a surgical procedure, they don't have to spend as much time in compression. So measuring the number of minutes per week that they spend in compression. And from there, then asking more questions about what they've had in the past for treatment. But again, has their conservative therapy been maximized? So because I want to present to the team, yes, they're ready to go. We have exhausted all measures, and now let's see if they remain a candidate for surgery. So starting with, has the patient had a full course of complete decongestive treatment? And many times they haven't, and we have to kind of start back at that process, because if they haven't had that, that's going to be considered the gold standard for conservative care. That's where we're going to start. And we may proceed with treatment, or we may refer them to a lymphedema therapist in their community to start with treatment. Once they get through that treatment, or if they've had an adequate course of treatment in the past, my next question is that I ask myself, is their edema stable? Over a series of, is there the difference between limbs been stable? And if it hasn't, they might need continued treatment and continued surveillance until we get it at a stabilized level. We certainly don't want to proceed with any kind of a surgical workup or intervention until we know that they've maximized in terms of limb reduction. And then the next step, or the next question I would ask myself, is their edema well managed? And when I say well managed, usually their compression strategy. We're going to hear a little bit more about compression strategies in depth, but the quality of the compression garment, how often they replace their garment, how many hours a week do they spend in compression, is it under good management? Because we might have to make some improvements in their compression strategy, again, before they take the next step and go up to consider surgery. And only if I can say yes, 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 would I speak up during our rounds and say, yes, we've exhausted all conservative measures to treat this patient. And then they may become a candidate, pending the medical workup that Dr. Carroll is also doing, and once they get their diagnostic imaging studies, and then we would take the next step. So that kind of is the precursor to any kind of lymphedema therapy before surgery. And that happens before the patient is scheduled. So when they come up to having a procedure done, lymphovenous bypass, for example, that preoperative period, we used to think of 2 weeks before their surgery as kind of buffing up their edema control. Hopefully we've set the stage already with that through that whole workup process. And then we may touch base with the patient again, depending on how long that course has happened. It may take many months for them to get all of the visits and workup done. So it may be that just the last 2 weeks before they come into surgery, we might have to intensively review their program and increase their edema control before they go into surgery, so they start off on the best footing possible. So that's going to be individualized depending on what the patient has done up until that point. A lymphovenous bypass they're usually done on an outpatient basis, and we may see the patient in the PACU or the outpatient department before they go home to wrap them up, and we do bandaging, so compression bandaging, before we get them back into a compression garment. So we would transition them fairly quickly into a compression garment because they're going to come in relatively stable in terms of their edema management. There's not going to be any distortion of shape of the limb, so they should be able to fit back into their compression garment as long as it was well-fitting before surgery. And we can continue with the MLD before, although now that having some insight into how ICG is being used, and since these patients are going to be worked up and have an ICG, I may change that strategy. And then light exercise in terms of doing their decongestive exercises. They can return doing within a week, and then we hold off on any kind of heavy-duty exercise for 6 weeks. And then they get back onto the same program that was successful preoperatively, postoperatively. And then we put them back into our surveillance model, and we would measure them at 4 to 6 weeks, 3 months, 6 months, 9 months, and continue surveilling them and to look at the limb volume and any kind of changes in their symptoms that occur over the next year. For the lymph node transfer, again, there's an intensive workup period, so oftentimes we have to touch base with patients a couple of weeks before the surgery to make sure that they're in good control, because we know that coming out of the transfer, we're going to remove all compression, and they're going to be out of compression for at least 3 weeks after the surgery. While they're in the hospital, we have our inpatient physical and occupational therapists see them, and most of our lymph node transplants for the upper extremity anyway are going into the forearm proximal forearm, so we're restricting range of motion at the elbow using an elbow, a long arm splint while they're in the hospital. So we keep the arm elevated and restrict the range of motion at the elbow, just as we would do for any other kind of plastic surgical flap that a patient was in the hospital for. We may add a manual lymphatic drainage for the trunk, and that would be depending on patient symptoms, but we wouldn't use any compression. The mobility considerations that we have outside the procedure itself, if Dr. Singla is taking the lymph node from the omentum, there's an abdominal incision, and that can restrict the patient's ability to sit up out of bed or roll. That may prove, we just have to instruct patients on how to get in and out of bed a little bit more comfortably and how to manage their in-the-room mobility. We also want to avoid limb dependency while they're in the hospital. The inpatient stay is probably averaged about 4 days, and then they're able to go home, and we follow up with them in the clinic at least at 3 weeks. They're following up in the plastic surgery clinic once before that, and then at 3 weeks, usually we'll look to see a clearance from the surgeon to see if we can start with compression. And we start with manual lymphatic drainage at about 3 weeks, and we're thinking about the placement of this new lymph node now, so the manual lymphatic drainage is going towards the new lymph node as opposed to the axilla. We're seeing that improvements in the patient's symptoms in the upper arm happen almost immediately. They report some change in the feeling of fullness or heaviness at the arm, and what's a little bit slower to improve is some of the more distal symptoms of edema. So we would use manual lymphatic drainage distally towards the new lymph node, and then add compression bandaging, fingers up to the new lymph node, so really just up to the elbow. And we leave the upper part of the arm unwrapped, and just through gravity, that's going to drain towards the new lymph node, which is now located in the proximal forearm. Range of motion restrictions we may keep into effect just at that elbow for the first 2 to 3 weeks, and light exercise, especially the decongestive exercises, so active exercises, holding off on any kind of resistive exercises for at least 6 weeks. And our plan is to start reducing the compression at about 3 months. So we would stay with the compression bandaging for the first couple of weeks, and then try to get them into a custom garment. And at that point, have them wear the custom garment during the day, and with a goal of at 3 months starting to reduce it. We would think about reducing the compression, again, by number of hours per week that they wear compression. We'd start reducing the number of hours they wear the compression, but guided by the patient's symptoms. So observing the patient's symptoms, asking for their feedback, and taking measurements of volume and circumference. And if they start to see an increase in their edema, we would add back a little bit more compression, number of hours in compression. As long as they're doing well, we would continue to remove the compression until the eventual goal would be for them to be out of compression all the time. So what we see in objective measures is their quality of life symptoms tend to improve pretty first, or symptoms improve first, and the volume and circumference measurements lag behind. Whereas we're decreasing the amount of compression that they use during the week, we're also not wanting to see any increase in edema. So we would probably look for 3 months to 6 months to 9 months to see them reduce the number of hours that they use in compression. So that really is very much on a case-by-case basis. Anecdotally, we've seen probably better progress in patients that get back to their more vigorous exercise programs, more so than patients who are not able to do that. So patients who have a good history with exercise and find it easier to get back into a very comprehensive exercise program have done really well. So I really think that the exercise component, beyond just decongestive exercises, but then really working on getting patients back to a more comprehensive exercise program is very much underutilized, at least by me over the past year, not realizing how important that has been. So I think that my plan is going to be to push patients more towards using exercise in that postoperative period as we start to reduce the compression. So that's what we're doing with the postoperative lymph node transplants. Again, the goal being to reduce the number of hours in compression, and we're really guided individually by the patient's symptoms and regular measurements, objective measurements. And then we put them back into our surveillance model, and we repeat the measurements at 4 to 6 weeks, at 3 months, 6 months, 9 months, and 1 year. They have a more comprehensive evaluation. They see the surgeon again, get a full workup, and we would continue with them on the surveillance model and continue to reduce the number of hours in compression as long as there is no increase in symptoms. Okay, thank you.